Hello, Kidney Warriors! James here from Dadvice TV, your online kidney health coach. And this is Dadvice TV Live. Now, for those of you who are joining us for the very first time, welcome. It is great to have you here. You're going to want to subscribe to the Dadvice TV YouTube channel because the videos we create here help educate you about kidney disease, lifestyle, and how it impacts the progression of your kidney disease. We get lots of great experts. We're very positive and we're very helpful. And for those of you that are new, let me introduce myself. My name is James. I am a kidney warrior, and I like to say I am kicking kidney disease to the curb. I was diagnosed with stage 5 and told there was no good, improvements in the future for me, that I was going to have to go on dialysis. But I worked so closely with my doctors. We formed a great team. I changed my diet. I started exercising, got my blood pressure under control. And as I lived a healthier and better and more active lifestyle, my health started to improve. Now, my kidneys are still shot, but I'm kind of not asking as much from them. And I get to feel great and be here with all of you today. Now, tonight we have a brand new guest here to Dadvice TV, and he's going to talk about patient empowerment. That's where you are part of the solution, which is exactly what my healthcare team did with me. I knew what was happening and why, which helped me to stick with what they were telling me to do and not skip pills or go off my diet. We're also going to talk about some game-changing kidney medications, and these are awesome. Can't wait for him to share these with you. And we're going to talk about preserving kidney function. So let's go ahead and give a great big Dadvice TV welcome to Dr. Richard Gibney. Hey, Doc.
James, good to see you, and look forward to a fun discussion tonight.
Awesome. Now, for those that are new, well, everyone is new to you here. Can you tell them a little bit about your background?
Love to. I trained back in the mid 70s at the University of Texas Health Science Center, San Antonio, internship, fellowship in nephrology. So I finished in 77 and went to Waco, Texas. They had no dialysis, and so we began a dialysis program. It was one doctor, one dialysis nurse. And I then retired from practice in 19. And at that time, we had 10 nephrologists in the group. We had over 800 patients on dialysis. And the great part of what we had done, we got tied in with the Institute of Healthcare Improvement, where they taught us the science of how to do continuous quality improvement. And in doing that, we developed the whole concept of effective how to do patient-centered care. And with doing this we were very involved in dialysis at that time. And so we started doing self-care dialysis in the dialysis unit, outpatient dialysis units. So they're very typically more sort of like, I guess you call it an assembly line, where people just kind of come in and it's put them on, get them off, and do it as quickly as you can. We radically changed that whole approach. And from the years 2015 through 18, 4 years, we went from 0 patients building their own machines to 70%, or over half the patients easily, meaning 560 of the patients were building their own machines when they came in. And we learned from that experience of self-care that if you allow and give permission to the patients to be involved in their care, dramatic things happen. And what we found was a 50% drop in mortality rate on dialysis, a 50% drop in hospitalizations. And we thought, wow, isn't it amazing how giving the patient permission to be involved in his care changed things in a radical way. So I retire in 19, and then in 20, I became involved in Governor Abbott's task force on how to improve kidney care in Texas. and I met Dr. Sharma, who's the chief of renal in San Antonio. We had a lot of fun with coming up with very innovative ideas. And so finally, in 21, he says to me, Richard, this is so much fun. Why don't you just come down here and be on the faculty in San Antonio? So now I have sort of a unique approach to life. I spend half my time in San Antonio, which I'll go into much more detail about how to take that whole concept of empowering patients and coaching and training them how to take control of their lives. But it's in the going upstream to CKD 1 through 3. So we left the dialysis arena and went on to the whole concept of how to preserve renal function, and have had simply stunning results, which I'll share with you in the program. That the changes through the two things that we do are, one, empower or teach and coach and train the patients how to do things, and then the other is these brand new medications kind of exploded on the scene at the same time when I started, which is back March 1st of 2021. So I've been doing this now for 10 months. By the end of February, it'll be a full year, and our data is breathtaking and should be very reassuring to all of the people out there that there is an opportunity to preserve renal function. It is a monstrous opportunity so that you can say, I can preserve renal function. And if I do the things that James has already talked about, plus using these brand new medications that are available, you can preserve renal function, and the whole concept of dialysis doesn't have to be a consideration.
Oh, that is what kidney patients are looking for. Now, I want to take a step back, Doc, and you have a website, empoweredkidneycare.org. Can you tell us a little bit about that and what information is available there? What could people learn from that?
Empoweredkidneycare.org started a few years ago, and we thought, I don't know a lot as opposed to James, who is a
I'm
computer.
a nerd. I'm happy.
He's a genius. He knows all this stuff, and as you can tell, I'm 75 years old. So computers, and I know how to do the basics, but that's about it. So anyway, so we thought we want kind of very similar to what James has done. We thought if you want to really reach a lot of people, you need to get a website. You need to start putting stuff on it. It's got to be put in. What we try to do is put it in a way where everybody can understand what you're talking about. And so it started with just kind of a simple concept of talking about self-care dialysis and how you can really take command of the ship. But then with our trip to San Antonio, the whole thing sort of exploded, saying, wait a minute, that's the wrong approach that we've been doing for probably 50 years, meaning that how can we find illness and how can we find disease, and then we can do some kind of procedures for the patient because he's got illness and disease. And we thought this whole concept of going upstream, and you thought, why would you go upstream? And the answer was kind of simple. If you went upstream, you could keep people healthy. If they stayed healthy, their quality of life dramatically improved. And so on arriving in San Antonio, Dr. Sharma, the chief of renal, was brilliant. And he said, Richard, why don't you just go around and look at our clinics and all the different junk we do? And so I said, sure. So the very first place I went was the Texas Diabetes Institute, which is a component of the medical school and university hospital system. And this is in the epicenter of the large Hispanic community in San Antonio. And this is the most poorest and the most marginalized people in the community who obviously need the most help to improve healthcare. So I'm working with people that are good people, they're smart people, and all they need is somebody to come to them and say, listen, I can coach and train you how to do all this stuff. And they just jump at it. And then also there are these brand new drugs that are available, and the combination of the patients becoming engaged and involved in their care, and with the use of these brand new drugs that are extraordinarily, it's the first drugs, for example, if you've heard of ACE and ARBs like lisinopril and losartan, Those came out 30 years ago. There have been no new drugs that do anything dramatic until the arrival of the SGLT2s. And I'll just mention the fact that a drug like Farxiga, Farxiga, is one. There's like 5 drugs now that are very similar, that are all SGLT2 inhibitors. And I can tell you right now, I'll start right now and say, I can't be your doctor, but you can go to your doctor. And if your doctor's a primary care doctor, a endocrine diabetes doctor, a cardiologist, you say, listen, there's this brand new tablet called Farxiga, or Invokana or Jardiance. They're all of them are very, very similar, minor changes. And these SGLT2s, they're a diabetic tablet you take once a day. And you say, well, when it's a new drug, you've got to do tons of studies to make sure it's safe, because you don't want to use a drug that's going to have compromised the patient's health. So what happens then is they do all these studies and they find out, gosh, this is amazing. These drugs, they preserve kidney function. They lock in kidney function, and they also dramatically stabilize congestive heart failure. So the cardiologists love this drug, the nephrologists, diabetic doctors, primary care doctors, everybody love these drugs because it's a game changer beyond belief. And just to give you some simple numbers, and I can repeat it as we go along because they're so stunning. You'd say, okay, you started with the SGLT2, and the data I'm sharing with you is 10 months old. So we've gone from 0 patients March 1st to over 500 patients. So we're moving at a pretty good rate. And so you say, what effect has it had on the patients? And we've gone from 1% of the patients on an SGLT2, such as Farxiga, and we're now at 39% in a 10-month period. And the same thing with empowerment. When we started in March, we were at 0 people empowered. And at the end of 10 months, we're now at 45% empowered. Now, we think that something good should be 100% and something bad should be 0. Why would somebody want something bad? So we still have a long ways to go. We're not where we want to be, but we think 39% or 45% is a dramatic improvement. And you say, well, that's kind of nice. That's kind of, that's attractive. But the punchline, which is devastating and absolutely stunning, is you say, well, how many of we track a lot of numbers, as you can imagine, because doctors love to track lots of data, a lot of numbers. But I'll just give you the most powerful one, which is how many new patients during that 10-month period of time went on dialysis. 0. Absolutely 0. None. So we were able to preserve GFR. And when we talk to the patients, and rather than saying GFR and glomerular filtration rate, we say, well, it's very similar to percent kidney function. And they go, percent kidney function. Okay, I get that.
Yeah, much
it's not
easier
exactly,
to understand.
You can understand it. So anyway, assuming, let's say if I'm seeing you in the office and you're a patient with diabetes or hypertension, and I should say now, we use it not just in diabetic patients, which is, a diabetic tablet, but we also use it in people with hypertension only that are suffering from a progressive loss of renal function. We use it in people that have various types of glomerulopathies like IgA nephropathy, where there's a progressive loss of function, and it locks in kidney function very nicely. It's quite extraordinary. Let me go ahead and
tell you.
If it's okay
questions real quick. If I'm not diabetic, are these drugs still something that I should consider and talk to my doctor about?
Absolutely. And the reason being is that if you're experiencing a progressive loss of function, then something has to be done so you can stabilize function. And if the things you're already doing aren't working, then drugs like Farxiga, Jardiance, Invokana or dynamite, and they're going to lock in your function so that you don't progressively lose function. And I see patients all the time that, as you can imagine, they come in, they say, well, my doctor or the nurse called me and said, you have to go to see the kidney doctor because you have kidney failure. Well, you can imagine how excited they are about hearing about kidney failure. So they
I
all come
remember
in and they're
those
crying.
days. Mine
So they
was
all come
worse.
in.
My doctor had the worst bedside manners and said that if I didn't start emergency dialysis, I'm going to die.
So all these people come in, and there's a spectrum of there's a spectrum of a loss of renal function from mild to moderate to more severe. And so when I see them, I say to them, you know, you're here, and let me reassure you that we can do things to preserve renal function. So instead of this being a nightmare and this being a terrible experience, you should be able to leave this exam room today with a sense of hope, with a sense of optimism, in a sense that you're going to take over control of your health. With that control, you're going to stabilize your kidney function, and things are all going to get better. So it's a dramatic change in the whole approach to patient care.
Yep. Now, I have a couple more questions from the audience. Philip asks, do these drugs help with protein loss? And I'm going to add to that, the patients that have used it before, have they had protein loss, which is usually an indicator that in the future they're going to have more serious kidney issues?
Great question, because we have not, again, it goes back to that issue of going upstream. So the first thing to do, day one, is can you identify the patients that are at risk? And I'll give you some terrible numbers that I'm ashamed. I mean, I'm part of the problem, as you could in the past, and not now, but in the past, that the United States renal disease systems is tracked, and if people that go and have their blood drawn, 92% were never told that they had a decrease in GFR. 92% that had a urinalysis never were told they had protein in their urine. 80% of those people never had a diagnostic or therapeutic workup to fix it or stabilize it. So somehow we've had a process that wasn't very good. The nurses are good, the doctors are good, they're all great people, they work hard, but if you have a process that's not very good, uh, every process is perfectly designed to get what you get. And if you have a crummy process, and that's why we changed our process and said, we got to move upstream. Waiting until you're CKD 4 and 5, that's not going to be helpful. Let's go back up to CKD 1, 2, and 3. So in doing that, the question Philip asked, we track decrease in GFR and proteinuria, and we give you a grade of, again, mild, moderate, severe, and with saying that, then that the kind of people that we've modeled what we're doing because we want to have credibility that what we're doing is good and it's productive. So we treat people with the SGLT2 inhibitors from a GFR of 60 down to 25. And so that's going from CKD2 down to the early parts of CKD4. So you can be a GFR of 29 down to 25. We're going to go lower eventually, but we wanted to establish the fact that we had great success because it's called the DAPA, D-A-P-A, DAPA CKD study, which was kind of the gold standard. There's been the Emperor study, the Creighton study, a whole tons of studies very similar to the DAPA study. So going back to that, yes, we track when we first start to see how much protein you have in your urine. Yes, we can show you significant drops in the degree of protein because, as you're aware of, protein is a marker of something that's not good and that is a good sense of things that are going to be damaging to your kidneys and cause a progressive worsening of renal function. And the same thing with GFR. We want to track that. So both GFR and protein in the urine, we do what's called a UPUC, urine protein creatinine ratio, on just a spot check urine. And it gives a very nice, just a simple spot check urine. And it gives a very quick answer on the degree of protein in the urine. And our experience has been that whether you're with a small amount of protein or a large amount of protein in the urine, it's effective in both of those in a very significant manner.
Awesome. Couple more questions. Lori asked, what about polycystic kidney disease? Are these drugs helpful for people who suffer from that?
Again, a great question, but the answer at this time I'd say is I don't know. I'm not aware of any studies that have used these drugs in people with polycystic kidney disease. And so I'm sure those studies will be coming out shortly, and then I can give you a definitive answer. And because we don't have those what do you call it meticulous research studies available, we have not pursued that angle, but that's coming in the very near future.
Awesome. And if someone's stage 5, can they still ask their doctor to consider using one of these, or should they not bring it up with their doctor?
Yeah, stage 5 is less than a GFR less than 15, and we don't use it in those patients. So at this moment, we'll go as low as 25, and I think there are studies that will be done shortly that will show you can go a much lower level. But having said that, to show you how powerful the empowered component, because you could say, well, what you do is only good for people that have a GFR of 25 or higher. But what I would tell you, in that 500 people that I told you about, we couldn't offer the SGLT2 to people that had a GFR less than 25. But over a period of 10 months, those people that have become empowered, and we've only had, I mean, to show you how good and smart and wonderful people are, we give them, let's assume for the sake of talking that I'm seeing you for the first time.
Mm-hmm.
And so I say to you, I'll give you a sheet of paper and say, here, this is going to be your homework if I can be your doctor. And they jump in and say, well, yeah, great. That's fabulous. And so the homework we give them is number one, if they're a diabetic or hypertensive or both, they have to have a blood pressure machine at home, a blood sugar machine at home, and they have to bring a list of their blood sugars and blood pressures to every office visit so we can look at it together. Again, we're giving them control and power at home, because if they don't feel right or whatever, at home they can say, gosh, my blood sugar is not right, my blood pressure, or if they're okay, they say, no, my blood pressure and my blood sugar are okay, it's not that. So it's very, very helpful. And then we can make adjustments to the medications, and we give the patients guidelines that they can make changes on medications at home. So they're, again, getting control and power. The second thing they bring to the office visit is their medication bottles. And the medication bottles they typically bring in a sack or a bag or a Ziploc bag or some kind of thing. But the reason why it's so important is we spend a lot of time talking about medications. And there are three things that the patients are just love to hear. First of all, what are you taking? Well, the bottles are right there. They're going to tell me. I don't tell them what they're taking. They tell me. Then they tell me, how do you take it? One tablet a day, one twice a day, whatever they're doing, a shot a week, whatever it is. And finally, why are you taking it? What the heck is it for? Is this a blood pressure pill? Is this a blood sugar pill? Is this and then what we do with this, which is really powerful, I say, well, here's an example. Farxiga, most powerful game changer. It's a diabetic tablet, but it preserves kidney function. And in addition to preserving kidney function, it also stabilizes congestive heart failure. And it's like, whoa, you mean for one tablet I get three things? Yeah, we like multiple things. If you're on losartan or lisinopril, yeah, it's a blood pressure pill, but it also gives you a mild protection to renal function, preserving renal function. And it gives you mild protection also to improving cardiac function. So we like drugs that do multiple things. So, and then finally, we tell all the patients they have to bring a patient advocate. And they go, what do you mean patient advocate? I say, typically it's going to be a family member.
Mm-hmm.
I don't care if it's a wife, a husband, a daughter, granddaughter, somebody. And I'll tell you, our prejudice is that the men male creatures typically are not terribly reliable. And so, like, for example, if the male creature comes on his own and he goes home, the wife will say, well, what did the doctor say? And he said, I was fine. That's not what I told him. I gave him a list of like 9 things to do or 3 things to do. And I wrote them down on his homework sheet and gave it to them because I give them the homework sheet back with a grade. And I graded A plus, smiley face, star, whatever their grades are. And they put it on their refrigerators or show their grandkids. They say, this is the first time in my life I got an A plus, a smiley face, and a star. But you can imagine the motivation. So the patient advocate is critical, and because that's their champion, that's their protector, and there's nobody beyond your family or a good friend that loves you more or cares more about you. And then they can talk about it at home and say, well, what I heard Gibney say was this, or I heard Gibney say that, and then they can kind of kick it back and forth. So bring your list of blood pressures, blood sugars, bring your medication bottles so we can talk about the pills, and then finally the patient advocate. And what we find is instead of me being in charge, I'm not in charge anymore. I'm the humble servant. I'm the helper. And the patients, they just sit there and they go through all their stuff, and I just sit there and listen. I have a yellow marker when I go over their blood pressure and blood sugars so that I'll say, well, the majority of the time the numbers are really good, so don't worry about it. It's just a couple of times they're not quite right. Or here's an area where there might be some improvement. So the patients are, as I say, they're smart, they're bright, they're talented. People, and I'll give you a quick comment. People would say, well, that must take hours, or it doesn't take, you just have to be efficient in what you do. I get all my notes done at the time when I see the patient. I finish my note and everything. At the end of the clinic, whether it's a morning clinic or afternoon clinic, I see patients 5 days a week, and I'm always finished and done. And then I collect all my data, and I'm done as far as all the data that keeps track of all the things we're accomplishing. So done effectively and giving the patient power makes the office visits very powerful.
So, Doc, when you described the male creature, oh my goodness, that brought back memories. In the beginning, I would go see my nephrologist, see all these different doctors, checking everything. And my wife would be, what did they say? Oh, I'm good. I'm good. I'm getting better. I'm getting better. That was it. That was not true. That's not what they were saying. I was slowly improving here and there, but they said so much more. And I started bringing my wife when she wanted to go, and it really helped us. It helped her understand it. And not only could we talk about it, but the biggest thing it helped was all of a sudden she realized why I was being careful with the foods I ate. No longer going to McDonald's and ordering the big meals and all the sodium loaded foods and all that. She understood why I need to start eating vegetables and not seeing them as a topping that I pick off or add only to a burger or something like that, but seeing that a salad was something that would be good for me, and eating apples and all that. It really helped with that. So I was laughing because I'm like, oh my goodness, that's flashbacks. I have a couple questions. So people are excited about these drugs, but there's a lot of questions about what GFR, what range are these good to consider?
We're probably going to liberalize our approach. But as I said, we're copying the DAPA CKD study, and so for people that had have a GFR from 60 down to 25, that's kind of the typical range. Um, and we're doing that because that gives us tremendous credibility, the tremendous success we've had. You can imagine there's a lot of people that are skeptical and say, well, I'm not sure I can believe your results because they're stunning, they're spectacular. I mean, when I tell people we've had 0 new patients start dialysis in 10 months in over 500 patients, they're just like, really? I mean, it shows you this is not a little bit helpful. This is powerful, and we've been waiting for this drug for 30 years, and there's a huge pipeline of new drugs coming that are also equally powerful or more powerful. There's a drug we haven't used yet called finerenone, and it took me 2 months saying that before I could actually say the word finerenone. It's like fine, Fine, re, and then none, None, finerenone, fine renone, but finerenone. And finerenone is instead of it going back to the SGLT2 is a glucose sodium cotransporter blocker. And what that means is that when you take this drug, it pushes more glucose and sodium into your kidney, your tubular system. And I'll give you a simplistic perspective. It alters the glomerular, the filters, and the tubules as far as their relationship. It starts to shut down the inflammatory process that's going on, for example, in diabetes or the other type of illnesses with progressive loss of function. It starts shutting down the inflammatory process, and therefore you don't get the scarring that progressively loses kidney function. Now, different on the finerenone, it's an aldosterone or mineral corticoid, but aldosterone receptor blocker. And you may have heard of a drug called aldactone or spironolactone.
I
That's
take
also
that one. That one helps me
and
sleep.
and it helps them sleep.
I take it at night. I
Anyway,
can't take it during the day because I can't stay awake.
that's an unusual side effect that James has that I can't comment on. But anyway, this is a much more precise, selective aldosterone receptor blocker that has an equally powerful effect to the SGLT2s. And the reason I mention it is we're going to start using it in the next few months. And we have a new protocol on how we're going to introduce that as a drug for certain types of people and also as an adjunct to the SGLT2 we're already using. And I would tell you that there are a lot of other drugs in the pipeline. There's another class of drugs called GLP-1, and there's probably drugs you've heard of like Trulicity or Ozempic, and they're shots for diabetics. They make your blood sugars better. But the thing that's really stunning about Trulicity and Ozempic, the GLP-1, is that it alters the metabolic component of what's going on. For example, as everybody knows, there's an epidemic of obesity in America. And the reason why we know that is a friend of mine showed me a picture of a group of people standing on the shore in 1950 watching a boat race at a lake outside of Fort Worth. And he said, what do you think about this? I said, well, it's a black and white photo. He says, I know that. He said, but what about the people? And I said, I don't know. They're a big group of people. He said, they're all normal size. There are no fat people in 1950. And he said, if you took a picture today, it's dramatically changed because of all the things that are going on. And so the good thing about Trulicity, Ozempic, and the other drugs that like that is they alter metabolism. So they're also very helpful at losing weight. So we have a lot of patients that we take care of that are on Farxiga to preserve renal function, and also on Trulicity to help improve blood sugars and to help lose weight. So the pipeline for really powerful drugs is beginning, and it's going to get even more powerful going forward. So the optimism and hope for all of you is huge.
All right, I got a few more questions. When patients start these new SLG2 drugs, how quickly or how soon do they start to see a reduction in the protein leakage? And is there a drop in their GFR when they start taking these?
Yeah. So again, I'm going to talk to you as if you were a patient in the exam room. And what do I say to you? What would I say to you? So I say, there's this new drug, blah, 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 Farxiga, that I've talked to you about. Now we've talked about the benefits of it, so let's talk about the potential problems
Mm.
that you should be aware of before you consider whether you want to take it or not. And there are three main problems that are potential with the drug. Number one is that you should be aware there can be as much as a 30% drop in your GFR when you first start taking it. So when we repeat lab work, I have to reassure the patients, don't worry. So let's say that their GFR was 40 and their GFR falls to 30 when we repeat the lab work. Well, I tell them, don't become hysterical, don't go crazy, don't think I'm nuts, because what happens is this doesn't happen in everybody, but it happens in some of the patients. And again, the thinking at this time is again that glomerular tubular imbalance that we're talking about that occurs with the sodium glucose blocking can sometimes produce that, but it's a temporary event. It stabilizes very quickly, and then you come back to the same GFR you were at before. And that's been our experience of preserving kidney function. But it is true that you can see as much as a 30% drop. So if you're a person that says, well, I'm not sure I could handle that, you shouldn't take this drug. But if you can be reassured that it's temporary and it's going to preserve your function, then you'll be fine. So that's one thing. The second thing is that we don't prescribe it in people that have a long history of urinary tract infections. And the reason right now is just we're just being cautious. And the reason for the being cautious is that if you're diabetic, you already have glucose in your urine. And this is going to make more glucose in the urine. And so we want to make sure we don't harm anyone. And so we've had 3 patients out of 500 that have had urinary tract infections, mild as an outpatient, treated with antibiotics, and we've taken a very conservative approach and stopped the Farxiga and not used it again. There are other people that we know that have just treated it and gone on, and they've done fine. We've taken a more conservative approach, but to show you how clever we are, for those patients that would fall into that category of having had a history of urinary tract infection problems, there's the new drug I told you about called phenytoin, and that's the aldosterone blocker. And that's the perfect drug for them because they're not at risk then for urinary tract infections. So we have a solution that's coming for that, and we'll be able to protect them in a similar manner. And then finally, the third thing to be aware of is the drug costs $600 per month.
That was one of my questions coming up. There's
And
Carol is out there. She's been asking, how much are these? I can't afford them. What can I do? And I said, don't worry, the doc has a solution.
And so the answer for that is we are fortunate at the University of Texas Health Science Center San Antonio and University Hospital System that we have a lot of state and federal money programs. And so for us, we're able to look at the people's coverage of whatever they have or don't have. And we typically, it costs them $2 a month or $4 a month, something like that. So it's a very reasonable price. And so we are able to solve the problem where we are. Now, where you are, you have to look at your coverage. If you have insurance, if you have coverage, talk to them, because what will happen is they may say, well, we won't support Farxiga, but we would support Jardiance. Or we won't support Jardiance, but we support Invokana. So there's 5 of them, and you have to work with. And then the other thing is the insurance companies have great programs for getting the drugs for very reasonable prices. So you have to call the drug company or email them or whatever to get to them and say, my doctor's, and you have to get your doctor obviously to write you a prescription for these drugs. So not me, but your doctor, go to him and say, I think this drug would be great to preserve my kidney function. What do you think? And if your own doctor agrees, then he can write the prescription for it. And then he usually will have somebody that will help you, either his own nurse, or if you have a social worker or a dietitian, a pharmacist, a good medical team, they can all work together to get it for a reasonable price. So there are a lot of avenues. So just because you initially are struggling to find somebody to help you, don't give up, because you can imagine, our practice is in the poorest and the most delicate group of people in our community, and we've been very effective in getting the medications to everybody. But that's because we've worked hard to make sure we have funding.
Awesome. Now, so these drugs sound absolutely amazing. How do we get this information to our doctors? Is there like a place on your website where, hey, here's what the drugs are? Or if they need to learn more about them, what do we do?
Absolutely. So you can go to empoweredkidneycare.org, and we've got tons of articles about it. You can go to Google and put in Farxiga, Farxiga, or Jardiance, or Invokana, or SGLT2 inhibitors, SGLT2 inhibitors, SGLT-2 inhibitors. Uh, uh, how can I find them? You can take that information to your doctor's office and say, listen, I don't want to be on a kidney machine. I don't want to be on dialysis. Everybody I know hates it. Everybody I know is miserable. And I want to have a good quality of life. I want to preserve my renal function. And if I preserve my renal function, my quality of life will dramatically improve. And you've got to help me.
Awesome. Now, Maria asks, once these medications lock in and stabilize your GFR, have you ever seen it start to increase later? Of course, that's what we all want to see, is it go up. I'm fine
The
with mine
answer is
stable now.
the answer is yes, we have. And but I tell them that's not our goal. I said the first day I met them, I said, now here's, and I write this in on their homework. I said, remember what we're doing. Our goal day one, and still is, that if we can preserve your renal function, your quality of life, and your control over your health, your optimism and hope is improved. And that's our goal. Now, if there's a bonus and it happens to go up a higher, well, that's great, but that's not our goal, because wherever we are, locking it in at 25 or 30 or 35 or 40 or 50 or 60, you're still going to have a better quality of life. You're not going to have to be anxious or fearful about going on a kidney machine. And that's a powerful, powerful story that you can share with your doctor, with your friends, your family. We've done the same thing. Like you can imagine, I've been practicing for a while, and I've seen generations where not just the children, but now the grandchildren of certain families are going on dialysis. And we're going to bring that to an end. We're going to get that stopped, where that those people can say, my grandfather or my father was on dialysis, but now there are drugs and there's behavior that if you'll teach me and coach me how to do things correctly, and if you'll put me on the right drugs, I can stop worrying about that. I'm going to stay healthy.
We will see in the future, hopefully, not too far away, dialysis as being so archaic and medieval, like leeches.
Well, and I've shown this video to James, and I show it in my talks. Uh, for all of you that have been Star Trek fans, there were movies made, and one of them was where they had to come back to Earth because a meteor was headed toward Earth, and they had to get the sounds of whales so they could turn off the meteor to make it miss the Earth. So Dr. McCoy was one of the people in the group with with James T. Kirk and the USS Enterprise people. So they're running around, and then one of the guys got hurt on a boat or something, and so they had to go to the hospital. He was taken to the hospital. So Dr. McCoy was running through the hospital, and he saw a lady in a stretcher, and he says, why are you in the hospital? What are you doing here? And the lady says, I'm on dialysis. And Dr. McCoy says, oh my God, the dark ages. the dark ages of medicine. So he takes down a pill out of his pocket and gives it to her. She takes the pill, and a few minutes later, she's running through the halls saying, "I just grew a new kidney." Now I must tell you, Dr. McGoy had a pill that grows new kidneys. I don't have a pill that grows new kidneys, but I can promise you that SGLT2s absolutely preserve renal function.
Awesome. And I love that clip. And when we were talking a few days ago, you had mentioned it and it brought it back. I'm like, I got to go watch that because I love when Scotty picks up a mouse or he's talking to the computer. He's saying, computer, computer. And the guy says, no, you got to use this. He hands him the mouse and he holds it up. Computer. Love that. All right. I have another question from the audience. Nancy asked, can a patient go on this drug with no protein in the urine and her GFR is 25?
Again, you have to go see. We have the answer is let's see. I think the best way to answer this is you have to go to your doctor and say, let me show you what's going on, and it depends on exactly your circumstances. But the answer, of course, is if you're having a progressive loss of kidney function and you want to have an opportunity to stabilize renal function. So have we done that? Yes, we have. But that's in a certain particular circumstance, and you'd have to share that with your doctor, both your primary care doctor and your diabetes doctor, your kidney doctor, because again, there's that in our protocol. There's a spectrum of mild, microalbuminuria, macroalbuminuria, nephrotic syndrome, a whole spectrum of protein in the urine. And then it also depends on what's exactly causing your loss of renal function. So I think the answer is yes, you can. You don't have to have all the parts of the story for this medication to be valuable and helpful. And but you'd have to talk to your medical team to see if that would be something beneficial for you.
Very good. Yeah, always talk to your doctor. I had another one here. Oh, here we go. Now, Sharon would like to know, are there any drugs that you know of or that you've heard maybe coming in the future for those that are already on dialysis? They're already visiting the machine.
What I would tell you is, I guess several stories. I think probably all of you have heard about the man that had the pig heart transplant.
Yeah, very recently.
Correct. And so I think the importance of that is that you can take a structure and take stem cells and grow a new organ, and that technology is rapidly progressing. So the days where you could take your stem cells and grow a new organ are very close. I think within 5 years, you're going to start seeing some really extraordinary things happen. So that's one component of the story. The second thing is that there's a company called Dialysis, and again, I have no financial interest in anybody. I'm just a simple doctor at the University of Texas.
You like to help people.
That's right. So I just take care of people and help them. But there's a company called Dialysis that's making a portable kidney machine that's like about the size of a small suitcase. Very light. It's not on the market yet, but it's coming. So that gives you a lot more flexibility. And this is for hemodialysis, so it gives you a lot of flexibility to do things. And they're doing the same thing with coming up with dialysis machines that are much smaller, much more patient friendly, and that's also very encouraging. And so I think there's a lot of new things coming up. And then I'd also tell you that I was with a group of nephrologists, and we were talking about a variety of topics. And they one of the doctors said, I'm curious. He said, Um, he said, with all the stuff that you've done with SGLT2 inhibitors, do you continue the drug when a person starts dialysis? I said, well, that's a very difficult question. And he said, well, why? I said, well, I've never had anybody lose renal function that had to start dialysis.
Hey, that's the best answer, Doc. Best one.
So I think the answer to your question is I don't have a immediate answer for you on how we can dramatically improve dialysis or kidney transplant or renal replacement therapy in general. But I can tell you that without question, we have a game changer opportunity to dramatically decrease the number of people that will require dialysis or transplant, and that is a really massive opportunity for everyone.
Yeah. Now we've got about just a handful of minutes left here tonight. Um, the empowering kidney patients. Now I got lucky. My doctor, he's very much like you. Um, Wants me to be involved. He encouraged me to constantly ask why. Why am I taking this? What is it for? To understand everything. And that really did help me to know why it was important to do all the things that my doctors, my other healthcare team members were telling me to do. Do doctors learn this from me? Is there a program to teach other doctors to do this, empowering the patient? Or, how does it get out there? How do we get more doctors to do this?
Um, I think we're if you go to our website empoweredkidneycare.org, it's pretty straightforward. I think there are a lot of I'm trying to think of the best. I can tell you the best answer without question. James is the best example of how to make it happen, and so as you can imagine, we give patients homework, and our homework is on our website also, the empoweredkidneycare.org. So if you want to say, well, gee, I wonder what kind of homework I should be doing, and so if you say, the answer would be, if you want the solution, it's yourself. If you go to see the doctor and you're passive and you're just there kind of for the ride, and you're not going to participate at all, you're not going to engage, you're not going to figure out what's going on, and if you can't, the perfect role model for how to change everything is you need to do exactly as James Fabian has done. Just said, I'm going to get involved. I'm going to get my family involved, and we're going to take control of our health. We're not going to be passive. We're going to find out what medicines we're on, why we're on them. If there are new things that come out, they're going to help me. We're going to find those too, and we're going to make sure that our doctor is our co-driver or co-helper in this story, and not just go there and say, oh, thanks for the prescription, goodbye. What's it for? I don't know. How do I take it? I don't know. Why do I take it? I don't know. So the best answer in the world, I'd say, is the patients can start the revolution to where you take control of your health and dramatically improve your quality of life.
Yeah. So I'll kind of bring up a little bit of my story and how I kind of got this working with my doctors. In the ICU, the nephrologist, I just did not feel comfortable with her. She had the worst bedside manners, but she got her point across. I did not accept that I had any kidney problems. I was 100% certain I had food poisoning. And she did a good job at finally making me realize, no, this is something extremely serious with my extremely low GFR. But my family doctor here in Cincinnati, he told me, hey, here's how we need to do this. We need to be like a football team. And you need one person to be the coach, the quarterback that calls all the plays. We all know what we're trying to do. We're trying to score, but someone has to be the one that calls the plays, and we all work together. We train together. And one of the challenges I had was he said, do this or take these medications for your blood pressure. My nephrologist, which I didn't really care for, I was in and out in these 10-minute appointments. She had different things, completely different targets and goals. So I got with everyone, all my different doctors and a renal dietitian, and I told them all the tests and everything you want me to do, you tell my family doctor. He's the one I'm going to listen to. He's going to make the call on what play we do. Everyone give him what you think we should do. Give your recommendations. And I had that one person who was helping me, and he works like a coach. I go in there, he's like, how is stress? We focus on stress first. Then we talk about medication. How's the family doing? And he kind of slips things in there, and we get along great. It has helped me get it all, all the advice comes from one person, and he is a huge believer in teach the patient how and why, and you'll get a better result. And, for me, that worked perfect. It was excellent.
High compliments to James, because he's shown you that this whole program and why I'm on this program is the most powerful person in this whole story is the patient. And if we will give the patient appropriate support, appropriate teaching and coaching, guess what? Magic happens, health dramatically improves, quality of life improves, and high compliments to all of you for taking control of your health and dramatically improving your quality of life.
Awesome. I could not have said it better. All right, Doc, thank you so much for being here tonight. Your first visit to Dadvice TV. I'm sure we'll have you back again to keep talking about great things and helping empower our community out there, kidney patients. And we educate them, we empower them, and we inspire them, as I like to say, to kick kidney disease to the curb. All right, this is the last show for this week, everybody. The schedule's on dadvicetv.com. I'm pretty sure I do have some shows next week. So I will see everybody next week. Bye, everyone.